Hello, my name is Caitlin D. Clerk, and I, along with my friend and colleague, Dr. Mohammed Garapour, am a co-founder of the Epidemic Urbanism Initiative. It's my sincere pleasure to welcome you to today's session on health and equity in architectural practice. Before we begin, I wanted to offer a few notes of thanks, first to our wonderful colleagues who have generously shared their time to be part of today's event. And finally, to all members of the Epidemic Urbanism community who represent 90 countries and counting. Now, I'd like to say a few words about the origins and ongoing work of the EUI as a way to frame today's conversation. The Epidemic Urbanism Initiative was formed in 2020 at the start of the COVID-19 pandemic to create dialogue around issues related to architecture, space, and the relationship to epidemic diseases. Since then, the initiative has grown to include a board of experts, 1,800 scholars and professionals, and a team of regional liaisons from more than 75 countries. Following the publication of a volume on architecture and urban epidemics, a series of workshops, symposia, and panels, and a successful architecture competition, as well as the creation of a growing archive of resources accessible on our website and YouTube page, the initiative has now become a didactic hub where scholars, practitioners, and others interested in health and architecture may access learning materials and news about events. So on the slide here, you see on the left-hand side a picture of our website as well as regional liaisons. You also can see the book that we published, and then on the right-hand side, you see our YouTube channel where you can find all of the conversations that we've hosted as part of this initiative. We do invite you to engage with us. You can learn more at our website, epidemicurbanism.com. There you can also sign up for our email list. You can also do so using the link you see here on your screen. And also on our website, as well as YouTube, you can see recordings of all of our past conversations. Importantly, since its founding in 2020, the purview of our initiative has progressed from a focus on epidemics and the city fabric to broader implications of the relationship between health, equity, and the built environment. And this is a nice segue to today's session, which explores timely questions for architectural practice, provoked by the simultaneous urban epidemics of COVID-19, social inequity, and climate change. And now it's my pleasure to turn the mic over to Angela Anderson, the Epidemic Urbanism Initiative's program coordinator, to introduce today's panelists.
Hello, everyone. It's my pleasure to introduce today's panelists. I just wanted to note that in an effort to devote as much time as possible to the discussion. These are shortened versions, but it is an introduction to the panelists' award-winning careers in research, scholarship, and design of architecture, which will provide some context for the coming questions. So today's session will be moderated by David Gloucester, who was educated at the Architectural Association and Imperial College. As REBA Director of Education between 2006 and 2021, he was responsible for our academic standards in over 110 schools of architecture globally. David is currently a diploma commissioner at the University of Architecture and Urbanism, Ion Minju in Bucharest, Romania. His publications include chapters in the Rutledge Companion to Architectural Pedagogies of the Global South and Architecture, a Gendered Profession, as well as writings on architectural pedagogy. David is joined by an accomplished group of a panel of experts, including Ruben Sepulveda, who is the director of Dear Architects, an architectural office founded in 2006 in Monterrey, Mexico. He obtained his bachelor in architecture at the Monterrey Institute of Technology and Higher Education, and a Master of Arts in Environment, Energy, and Sustainable Design from the Architectural Association School of Architecture in London. He's been recognized by the Mexican National Social Housing Prize and was selected as a Mexican representative in the Latin American Architectural Biennale in Pamplona. Robin Gunther is principal of Perkins and Will and senior advisor to the global nonprofit Healthcare Without Harm. She works, practices, and advocates at the intersection of healthcare, architecture, and sustainable policy. And she is a Robert Wood Johnson Foundation Culture of Health leader and the author of Sustainable Healthcare Architecture. She developed the Green Guide for Health and Lead for Healthcare. She is currently on the board of the Health Product Declaration Collaborative. Timothy Odeale is the head of the Department of Architecture at the University of Ibadan, Nigeria. He obtained his PhD in architecture at the Lincoln School of Architecture and is a member of the Nigerian Institute of Architects, an associate of the Higher Education Academy of the UK, and a member of the Royal Historical Society. His design, supervision, and construction activities involve new town developments, health and educational facilities in Nigeria, Cameroon, Norway, and the United Kingdom. Christiana Kara is partner and board director at White Architecture, artistic professor of healthcare architecture at Chalmers University of Technology in Sweden, and a member of the board of the European Health Property Network. She has over 20 years of experience in planning award-winning healthcare environments in Scandinavia and internationally, including Södra Älvsborg Hospital Psychiatric Clinic, the Queen Sylvia Children's Hospital in Gothenburg, and Cambridge Children's Hospital, and extensions for Carlsbad Hospital and Panzi Hospital in Congo. Henry Chow received his master's degree in architecture from the Harvard Graduate School of Design and has more than 30 years of experience designing and planning large-scale projects for healthcare and educational institutions, recognized as exemplary projects. His Ng Teng Feng General Hospital in Singapore received the 2017 AIA Committee on the Environment Award, and his Cleveland Clinic Miller Heart Pavilion in Cleveland, Ohio, won the Most Beautiful Hospital in 2009. Kandakar Kabir holds a master's in architecture and landscape design from the University of Sheffield. He seeks engagement in people's everyday design processes, and his research and practice focuses on ecological landscapes and people-led design and planning. Kabir is the co-founder of Co-Creation Architects, winner of the UIA 2030 UN Habitat Award, and is a core team member of Platform of Community Action and Architecture that works in Bangladesh and Community Architects Network that works in 19 Asian countries. Sahar Atia is an emeritus professor of urban design in the Faculty of Engineering at Cairo University, where she was head of the Department of Architecture from 2013 to 2017. She is currently a member of the Supreme Council of Urban Development in Egypt, a member of the Stakeholders Advisory Group Enterprise UK Habitat, and the co-director of the Social Habitat Working Programme in the Union of International Architects. In 2021, she was appointed a member of the Egyptian Parliament. And finally, Femke Venstra, a board architect, interior architect and partner in the Netherlands, is unable to join us today, but we appreciate her contribution to the field.
And now, David, we turn the mic over to you.
Thank you very much, and welcome to our external audience, and many thanks to Caitlin and Mohammed and Angela for the logistical support. We have a distinguished and extremely diverse panel today, dealing with, I think, extremely complex and profound issues. I think just by way of some opening remarks, it's important that we understand that the pandemic in global history is actually a recurrent feature. We have found ourselves in this moment in history, locked down through the enigmatic means of COVID-19, but the reality is that as far back as classical times, there have been recorded pandemics. And lest we forget, in the mid-14th century, as many as 200 million people may have lost their lives through the Black Death. That in the 19th century, starting in 1817, there were at least 7 recorded cholera outbreaks in which at least 2.5 to 3 million people died. The so-called Spanish flu immediately after the First World War was responsible for the deaths of at least 50 million people. And that pandemia such as HIV/AIDS has also been responsible for 35 million deaths. Where we're at with COVID, we don't quite know in terms of recorded deaths, but it's certainly around the 7 million mark, maybe as much as twice as that. So what do we learn from this? We learn that the pandemic must be expected and it must be proactively anticipated. In other words, that we need to be strategically ready for this. And that whilst these events, pandemia, are catastrophic in their effect and extraordinarily transformative in terms of the way in which we do things, they also represent opportunity. And it's impossible, perhaps, to imagine today's meeting happening without the medium of Zoom, which we've all become used to as a second skin, as it were. Now, I suspect after each pandemic, there's been a notion that perhaps we reset society. And it seems to me that opportunities like those presented by the EUI suggest that societal reset must be vigorously promoted. But the reality is that, of course, a pandemic nowadays, in particular, develops so-called cures. I use the word advisedly, resulting from the onset of pandemic disease. But pandemics are politicized. We won't go too deeply into that because of the power that the control of a pandemic gives to government, and of course the pharmaceutical industry. And where power resides, so does profit. The second point, just by way of introduction and quickly, is that we are architects and urbanists. So we're not politicians. We're not in charge or controlling governments. And we have to understand the context in which we operate, which is pretty modest. We are, as architects and urbanists, I think, have a very strong idea of the profound impact architecture can make. But the reality is that we're not the people who pay for it or make the decisions about its implementation. So we, I think, through events like this, through the discussions we'll have today, can promote change by stealth. And that stealthy change can happen through education and ethical strategic shifts within the profession. And perhaps also, I think, reimagining healthcare in a more democratic, a more accessible, and a more cost-effective way. The power of imagination is incredibly potent, and I think it's important that we grasp the opportunities represented by events such as this most recent pandemic. Yet healthcare management, of course, has become politicized to the disadvantage of those requiring it. Now, today we've got a lot to pack into a short period of time. We have about an hour and a quarter ahead of us now. And I think what we're trying to do is not to provide answers, but to discuss issues. And the discussion of those issues then provides a provocation for others to think about how they will act strategically. The first question, and it's one which I'd like everyone on the panel to respond to, is what the ongoing impact of COVID is in their region, or for that matter, the issues of what they would like to retain as a result of the changes that COVID has developed. And I'm going to try and go around the screen in terms of the faces at the top to the bottom, if that's okay, or I might work from the bottom to the top and inwards. But Sahar, if I could ask you to take the first question, please.
Yeah, sure. Thank you, David, and thank you for all the organizers. Quickly, of course, the pandemic had impacts on cities, communities, and people. And I see always that despite the negative repercussions that we had regarding health issues, but it revealed actually the weaknesses in cities. So we can, for example, in Cairo, the importance of public space, the importance of the multifunctional buildings was really revealed. And we have seen, the fragile cities, we have seen how the vulnerability in cities and the impact on popular conceptions of what is most important for a good life. So we got lessons actually from this. And we learned also how societies can foster the collective improvements to well-being. I will mention two major impacts, one regarding architecture and the other regarding education. And I will start by education because we had this online learning and teaching, which we had not really experienced a lot in Egypt before. And so this is a thing that, especially for design studios, for example, it was really hard to follow up with the learning online, with all the challenges we had for networking. And so this is a thing that I think now we are ready to face any crisis regarding education. Also, in all the new cities now, they are really working on multifunctional buildings where the citizen can find all essential needs. Most of these are currently under construction, of course, but I think it is important that we can use these multifunctional buildings to where you have every need for the family to really, if in case of any lockdown again. Thank you.
Thank you very much. I'm going to ask the same question of Kondaka, please.
Yeah, thank you. Yeah, I'm from, as you know, I'm from Bangladesh, and I live in a small city town. And I work with communities. So when the pandemic started, when it was we heard that it started in China, then in Europe, and we became, very cautious that is coming, it may come. So suddenly we were advised not to go to the communities, and it was a big shock for us that we cannot, because how can we work without going to the communities? So we had to find alternative ways, how to work with those low-income communities for housing and other things. So at that time, what was and many we really wanted to be together and work together, and we were foreseeing that something is coming, and from the government also saying that it may be very bad if it comes to Bangladesh, because it's a densely populated country, and especially the low-income communities are very dense. So what we started do that, because we know the contact of the people, and they don't have this phone. Many of them they don't have, but they have a cell phone, but not those with they can see, use not good one. So we started to call the community leaders. What can we do if the pandemic hits? So at that time, actually, the impact, we say that without going to the communities, we got together again in a different way to fight. So that was, I think, a good thing we learned. And within 2 months, we could organize people to write a guideline how they will use their own spaces with health guidelines. And for the first time, the impact for me and for the architects, for the first time, we learned that health is the center of our design. Before we were designing and we were addressing, but it was not, we didn't do it consciously. We are not aware at that time, but now we are doing it consciously, that health is the center of our design.
Thank you.
That is, yeah. Thank you.
Thank you. Ruben, I'll throw the same question at you, please.
Sure. Well, I'm in the north part of Mexico, and well, when the pandemic was on, so all the construction stopped, like in all the world. But here, after we finish this pandemic, or at least as it seems like, everybody turned, like, there's a lot of work, a lot of social activity. This is partisan behavior galore. These constructions for mercantile use but everything is like without any subject. I mean, there's no let's concentrate. It's like everyone is trying to take the time out and just working themselves out, right? So like everybody's like doing too much very fast. We're in this speed mode right now. So the thing that have changed is the awareness that well-being and health is something we need to focus on. But they are taking it, at least right now, more in the private sector, because in the north part of Mexico we have these rates of obesity, the highest in the world after the USA. The north part of Mexico is where we have these kind of lifestyles, very sedentary. So everyone in every university is trying too hard, even the government, so people could stand up and do exercise and notice the importance of being healthy and eat well and those kinds of stuff, right? And that's what the mindset is going on. I mean, there are no still the activities fighting really hard in architecture for those stuff. They're trying to, but we haven't found the way. I mean, in a big mode. And what I would like to continue, I mean, what do you wish to continue, is the time and concentration we have during the pandemic to give a study and reflection and exercise and reading, so we can give content to our work instead of just being in the speed we live every day. Thank you, David. That's it.
Thank you very much. Robin, could I ask you the same question, please?
Sure. You know, I think one of the most interesting things that happened in the US is that we realized in COVID that we haven't come as far as we might have thought we had in transforming the typology of hospitals beyond the first era of infectious disease. Meaning, you know, hospitals used to be sort of towers of disease placed in the outskirts of town for infectious populations. David, I think you'd agree with that, right?
Yeah.
And you know, generally speaking, the developed world, probably since the 1930s, has believed we're more in an era of chronic disease, right? Of lifestyle diseases, et cetera, not infectious diseases because of antibiotics, et cetera, right? Because of medicine and actually public health advances. So I think what we learned in COVID is that we still commingle potentially infectious patients and non-infectious patients routinely in acute care hospital buildings. And what I've seen coming out of COVID is more intentional rethinking of that on the part of health systems. Believing, I think, as you said, David, that this could well be the start of a resistant infectious disease period, moving on from chronic disease. And so how do we take healthier populations, women giving birth, people dealing with chronic cancer, people dealing with diabetes, with these chronic diseases, and more specifically, address their health needs in settings where respiratory infectious patients are not commingled. So that's, and I'd like to see that continue. I think that would be good from an equity perspective, from an environmental perspective. And it's really just started.
Thank you very much. Timothy, could I ask you to come in?
The question is very important to us in Africa. I'm based in Nigeria, working in Lagos and Ibadan. When the COVID outbreak, the pandemic happened, it was a very serious issue for us in that part of the world. Knowing fully well the population of Nigeria, we are over 220 million people in Nigeria at the moment. I think by far the largest nation in Africa. And from the look of things, if you want to pick one out of every Black person in the world, 1 out of 5 is a Nigerian. So that means if you want to talk about the Black population, in the whole world, if you talk about every other person, I don't talk about Nigeria, you have not started. So because we are the chunk, and we are everywhere. So what affects us in Lagos, what affects us in Abuja or Zaria, Kaduna, Maiduguri, in the center, in the urban centers of Nigeria, actually is important to the whole world. So having said that, we have that challenge when COVID, we have the outbreak. Many of the things we were doing in one part of the world are of less concern to the global north. So the global north faced their own people and kind of didn't even communicate with us back in our own part of the world. And we have to make a lot of noise, before they, come to, even give us any attention. In fact, it got to a point that vaccines are not even available in Nigeria for the first 6-9 months of the, infection, which is very strange. We couldn't get it. We are not even put into calculation at all. And eventually, when vaccine came to Nigeria, it only have 1 month expiry date. Before it got to us, even the whole thing has expired. So it talks about equity. It talks about the world attention to that part of the world. So when we're talking about epidemic, pandemic, the WHO has to wake up. We have to do a lot of things to ensure that things were done very early enough. So we had experience that from our airports, international airports, that's the entry points of the disease into Nigeria. So immediately governments, step up their various measures to kind of draw up a kind of parameter to check people coming into the country. And that really helped the spread of disease. In fact, the platform done by the government, we have what we call the NCC platform done by the government, is now a kind of a pace setter for the other part of Africa. If other African country came to Nigeria to borrow from us, the platform, the various protocol that the Nigerian government sat down through the academia and the various teaching hospitals were able to draw up. So that helped a lot of other parts of the African nation to get grip of the disease. So in the part of architectural practice, the architectural architect are also called upon to think of ways, to kind of shield people that are what we call the quarantine, design of the quarantine and all that. Like we gave them some advice. So the COVID-19 experience is a root shock, that we need to prepare against future occurrences of this kind of disease. It's a wake-up call, and we are still on it, trying to, stop the spread of it. It's still on, but it has drastically reduced in our own part of the world. We have other communicable diseases apart from COVID-19. We have, Lassa fever is even there. That is rampaging. It's not, nobody's talking about it per se, but we have them in some pocket places in some part of Nigeria, and it's even highly infectious than COVID-19, spread by rodents. So that calls upon measures, policies for sanitation, the environmental sanitation, and that comes into regulation in terms of housing development, in terms of environmental development, that we architects and architectural educators were actually involved in designing a way out for the populace. So we had a lot of challenges, and that COVID-19, as I said, is an eye-opener that gives us a kind of window on how to solve a larger problem that we want to come in the future. So I hope that as we go along, I will to give you other examples of some other cultural way that were stepped up during that period of epidemic and pandemic that helped to reduce the impact of the disease in the housing sector and to the populace at large. Thank you.
Thank you. Thank you. Christiana, please.
Yes, thank you very much, David. I think I will agree with all of you. Many of you have already mentioned that the the pandemic in Sweden has shown very clearly or reminded us that architecture and design matters. We have been, it's nothing new. We have, as you mentioned, David, the cholera and the other outbreaks such as TBC have been actually recurrent events in our history, and they have been changing the way we plan cities and urban design as well as buildings. We have the Paimio Sanatorium in Finland is, I think, the best example on how a building can actually heal. The epidemic has shown that when antibiotics and drugs do not actually work anymore, we need to do something else. And the physical environment is an important element when drugs and antibiotics do not help anymore. Of course, for me and architects that work and design healthcare settings on a daily basis, it is obvious that the way we plan build environment has an impact on well-being and healing for both patients as well as staff. But it is probably one of the biggest learnings from the pandemic is that it is important to think about health even when we design other buildings such as housing, schools, working spaces, public air spaces, outdoor spaces. One learning we bring with us is learning, as Sahar also mentioned, how important it is to have access to quality outdoor space in cities, especially close in proximity of residential areas. We didn't have in Sweden, the policies were, we didn't have lockdowns, but we had a limitation of movement and access to indoor public spaces. So the outdoor spaces have become extremely important. And somehow in the planning of cities of the future, I think we will see discussions about a possible conflict between the importance of the densification of urban settings that goes into the direction of sustainable transportation and sustainable cities. On the other side, the need of keeping and protecting green areas in urban settings because it is probably the most important element of healing and health promotion in a urban setting. Another thing I would like to say is that we have seen in Sweden for the first time in the last few years that big cities such as Stockholm, the biggest cities, is not growing anymore. We have more people moving out from big cities than moving in, and this is an interesting phenomena that has been probably also pushed by the pandemic. The possibility of actually working remotely or working parts of the week from home or other settings have created opportunities to move away from large cities into smaller cities. And some researchers speak about the renaissance of the middle-sized city. And I think this is also an interesting phenomena, how this, if it is a global phenomena or something that we only see here. Coming to healthcare architecture, I think the pandemic has reminded us that good health is not taking care of sick people, but it is that promoting health is actually the key number one. And health promotion means, of course, to work in a much broader sense with architecture and design as designing hospitals. The epidemic has been a catalysator for a shift of system, at least in Sweden, from hospital-centric healthcare to a more community-based and ecosystem of healthcare provision, where healthcare is not provided only in hospitals, but even in homes and in community centers, in primary care or mobile care. And given the opportunities of e-health and digitalization, which has been pushed extremely much during the pandemic in a very positive way. So more to say about that, but a lot of good things have come and hopefully will continue to develop in a positive direction.
Thank you very much. And winding up this part of the session, Henry, sorry you're last, but somebody has to be.
Not a problem at all. And it's a great thoughts from a lot of people. And as a practice architects, and frequently that the project that we designed and is enhancing the strategic or business objective for our client, whether that's institution or private companies, and then that become a tool of the sort of kind of competition among them. And New York City, where I reside, and was one of the the first one get hit pretty badly. And then in a city where that the competition is the norm of life, I actually observed and I saw that our clients that come together actually thinking about sharing the facilities. And I think that's a fundamental when a institution open up their border, their wall, open up their campuses, and linking the things, sharing together. That is actually quite a remarkable things, because that they're shifting around, and then we all know how challenging to put the facility up and how long does it take, and able to that kind of nimbleness, the sharing become one of the critical things I saw that I really like to see that continue. And the second one, which I think that Christina Starr also mentioned, that is that I think the pandemic, and to a great degree, like many of us, start realizing that the limitation of the facilities, and then and especially that also coincides. I don't know about the other places, and but at least for United States, with the hyper escalating construction costs, and it just go with everything. And then and I remember in the New York Press, one of the directors, facility director, in one of the sessions, they say they start saying, well, not every challenges have to be resolved by a project. So we start looking at something that beyond the non-facility solutions. But once you start going to non-facility solution like digital health and telehealth and many others, then we start recognizing and realize again how important facility is. And then that in terms of whether that's, it just may not be the hospital in the traditional healthcare setting. People mentioned about the workplace being home or playground, educational places. I think education in the United States, school is a big issues. I think that, so in a way, I think that further intertwined between what facility architecture and urban environment to health. I think these are things that you come around all circle, realize how important it is. I think that's a wonderful opportunity to let us rethink again.
Thank you very much. I think these responses illustrate the depth and diversity of everyone's experience and provide an insight into the extraordinary way in which we had to reset our parameters for almost every aspect of activity. Now, I'm going to read out the first of these structural questions, and we won't have the time for every one of the panelists to answer, but I'll read out the first question now. And broadly speaking, I would regard this as being about the issues of building production and the patronage of the project. So production and patronage. If architecture is to actively facilitate global health equity, how can this be made attractive to those who invest in architecture and construction for profit? Because we as architects and urbanists, we only exist, we're only useful if we're spending somebody else's money. And the issues of money are very rarely discussed, I think, particularly with students of architecture, but they're fundamental to implementation. So how do we facilitate global health equity, but make it attractive to those people who commission projects? I'm going to start with Zaha again, because I'm aware that she needs to dip out of the session for a short period of time. And then I'm going to go to you, Henry, again, if that's okay. So Zaha first, please.
Thank you, David, and apologies for all the panelists. This question actually has two parts. The first part is talking about health equity, and the other part is about investing in architecture, because we cannot apply the investing in architecture on all communities. I mean, in a city like Cairo, where you have a very diversified typology of communities, you have the informal areas, unplanned areas, you have the social housing, you have the old quarter district, the heritage sites and district, and then you have the new compounds and new cities. So yes, for those who want to invest in architecture, it was very clear and wide that they used the health equity regarding their advertisement and their marketing about green areas, about public spaces, and they could really invest in their construction in architecture. And truly saying that the construction during and post-COVID has never stopped in Egypt, in Cairo, or in new cities. It always boosting, and it is one of the major industries. But still, when we speak about equity, we need to question the terminology for some districts. And first we have to ask whether it is applicable or not. And then we can discuss whether we can invest in it or not. And I think that many cities already planning for life after COVID-19 and thought about what to do with a big range of investments to pair economic recovery with environmental sustainability, with construction, with an emphasis on clean forms, urban mobility, energy efficiency. So yes, you can invest in this in particular communities, but difficult to apply all over the communities. Thank you.
Thank you. Henry.
Yeah, I think this is actually a very interesting question. I know just even before the pandemic, and I think in the last few years before, that I think we believe that we have started seeing the new trends of development of health and the development, and where I think that what I will phrase, the health become a new form of wealth. That the walkability of place, that the place that emphasize activity, active living, wellness, and then even well-being, and that it start attracting that the highest development and the highest investment for many. And so in that aspect, I think that the pandemic, they sort of kind of way further reinforce this message when I think that one of the panels says, that living in a dense city, that, having and able to walk outside is luxury, especially in the pandemic time. So the health, I think, is in some ways a new form of wealth. And because of that, and then we have to be, as a planner designer, we have to be very cognitive in terms of the distribution of that. And the second thought, and David, I thought was rather interesting, of my client at Cleveland Clinic. And I remember I was doing the project in Cleveland, and the Cleveland Clinic in the early 2000s, University Circle. Isn't that one of the best places that you actually want to be in? And after like maybe 10 o'clock at night. So he said this to me, he said, look, Henry, that, as a Cleveland Clinic, we actually don't have a challenge recruiting, attracting people or a potential physician coming to Cleveland Clinic. We have challenge attracting people come to Cleveland. Right. So, and as I said, that when that happened, is that I think healthcare in many places I can see, where Cleveland's located in Upper West, in the New York City Upper West, and the Upper East Side. And Philadelphia, the Penn Medicine, I think the healthcare institution become one of the major economic engines, and they start reaching out of their campus and wall, connecting with facility, because it's a place that was a concentration of well-compensated, highly educated, and the very, very active demands needs. And then so that I do see, when I think Robin said earlier, early hospitals tend to be located on the edge of the cities. And then I think that will start to change. Even I think that the hospital or these type of health-related facility can become the major economic driver, not only for the community, it could be even for the city as a whole.
Thank you very much. Who else would like to have a go at this question? Thank you, Robin.
I was actually thinking about it in a slightly different way. And if you're talking about the for-profit sector, I think, the market responds to two things, right? It responds to market demand and it responds to price. And I think when you see what you were talking about, Henry, the healthier building, healthy community movement, that's creating, at least in the US and North America, it's creating a kind of market demand for well-certified buildings, for certain kind of imprimatures of healthier building world. But I think it's interesting to think about the work that the UN has been trying to do with the Sustainable Development Goals, and really around this idea of valuation of ecosystem services, that until there are price tags placed on environmental degradation, until somehow, I think that's been really driving at the monetization of co-benefits and environmental and health benefit. And it's not a movement that's gotten very far, but I certainly think that's another whole stream of inquiry of how do we basically respond to the for-profit motive being, in essence, responsible for much of the ecosystem and health degradation that we have across the planet, not just in the developed world, but everywhere.
I think that's absolutely right. But I think one of the things that's beginning to come out of the discussion is that we're not just talking about the healthcare sector per se, but we're talking about the healthy city generally, the healthy exterior space, the healthy interior space, the whole notion of how we promote well-being within architecture and construction. And this question of us as architects and urbanists spending other people's money, the problem that we've faced and probably always have done as architects and urbanists is that value engineering in one form or another has always been this spectre that haunts architecture. And it means that the potential benefits which we wish to deliver generally get shaved off the edges of projects, and then they get shaved again, and they get shaved again, and you're left with an essence which is not as potentially beneficial. So how do we, I'll use the word sell, but perhaps promote is better, but how do we promote the benefit of the healthier building, the healthier construction project, the healthier piece of architecture to the people who pay for it? Because developers are ruthless. I mean, we have to live with them, otherwise we don't work. But the reality is that the profit motivation is pretty ruthless. How do we promote those benefits? Because if one recalls 35 years ago, the idea of a building's ecology and sustainability and reduced embodied energy and so on was a hard sell to a developer. Now it's beginning to be something where the better type of developers say, well, you tell me what the BREEAM rating is or the LEED rating is, because that they then see as marketability. Right. Now, I think we're dealing with more intangible issues here, but if one of you would like to answer that question, how do we go to the patron and say, we need to make healthier buildings and the advantages to you are this, this, and this? Yeah, Kondika, thank you very much.
I think what you already touched upon that, how we can value engineering, because we have seen in our context that maybe 10, 20 years before. It was many buildings were not designed and were not sold the way it has been doing now, like maybe in a different aesthetics or view, or riverside apartment, or maybe a location, and the developers, they are using it and they are valuing it and they're selling it. Oh, this is a park view apartment, or this is in the center. So I think the same way, if we value health, and they can, maybe they don't know this thing now, but if we design that way, and the developers can sell that this is a healthy building, so you can pay more for this. And another thing what Robin mentioned about this, I think the demand side. If the demand side, and in Bangladesh, that's how it happens. When the demand side is strong, then the supply side really become more responsive. So and even from the government also, that's how in our country it happens. Then when the people want, we want this, then the government also changes their laws and that type of thing. So both ways we can work, and create demand side from the community level, and through awareness also, and showing good examples that this is what you can get. And you can demand.
Yeah, no, I think that's an incredibly important point, that you drive desirability through demand. And then that's then a question of actually sensitizing the, if you like, customer audience. I'm going to move us on to the next question now, which is really to do, I think, with the questions of education. And the question is essentially this, that this is an academic question, but the graduate of today is the emergent practitioner of tomorrow. So their sensibilities and their understanding and their motivation is very much apropos of this conversation. So the question is, how can the value of physical and mental well-being be embedded in the histories and theories of architecture, so that students and graduates and young practitioners can catalyze better and more equitable design? Now, from point of view as an educator, the students are pretty touchy about histories and theories of architecture, because they somehow think, oh, this is complex stuff. Why do I need to know about Viollet-le-Duc, or why do I need to know about Mises' theory of universal space? Why do I need to understand these things? So we're saying, the question suggests that we have to embody some other values in these histories and theories of architecture. So we turn out graduates who are better attuned, if you like, to health as a general issue in design. And Christiana, I think you were interested to take this one.
Thank you very much. And I think Ruben has also, well, I'll take the word first. So the question is, of course, for me, very, I burn for this question a lot, since I am a teacher in architecture and I meet students every day. And we have at Chalmers University of Technology one direction that is healthcare architecture. So we teach students how to design healthcare buildings. But usually I tell them on the first day of the studio that learning to design a building for healthcare is learning to design a building with health in focus, and that probably they will not work with hospital or healthcare architecture as practitioners, but they will learn how to deal with health, even if they design housing or schools or parks or public spaces. The teaching is very much about how to incorporate evidence-based design in our processes. And I think if I have to be rather frank, I think we need to focus in embedding research into the design process. We have two strong, unfortunate separation between the practice and research today. I am an example, so to say, in Sweden, in a Swedish context, of a practitioner that is working half-time in a university to link and bridge the design with the research and the teaching. But we have still in schools many professors and teachers do not actually work in practice, or the opposite side. In my practice at White, we have an internal unit that only works with research and development, so that we are really keen on bringing research into the projects. And why is that important? It is important because when we do design, research and evidence evidence from research or best practice, it's actually a very good tool to take crucial decisions in design processes, and also a very good tool to make these decisions shared between the architects and the stakeholders and the clients and the collaboration partners. So it's absolutely never a barrier or a disadvantage. It is a great advantage to learn how to bind together practice and design process with research and evidence. And to learn to do that, of course, university is a good ground for that. So
thank you. Thank you very much. Ruben, come in, please.
Yeah. So I think it's a good time for universities to question their agenda, because architecture within history makes its own meaning. I mean, you got to adapt to its time to know what architecture is serving for. Students right now have been very confused because they don't understand what they can do with architecture. They are just serving as decorators to developers, making some forms. They feel like there's a void in what they can afford to society. So they need a motif. They need something to hold on so they can make their designs and have some relevance, right? So if we take in our courses, and design recovers its meanings as place of well-being, so we can co-live with nature and human, those are the parameters to measure and follow for these students that are looking for something. They feel right now like orphans of what they are doing, right? So they will look for the well-being of people with nature, not only for humans. I mean, how to co-live with that. And of course, in theories and history should also take more into importance, because we always have learned about this modernism and about the technology and stuff. But we know that the modernism began after the Spanish flu and all these healthy issues that make the forms of modernisms and interest of modernism. And most of the people don't know about it. I mean, the beginning of modernism is well-being after these pandemics, right? Also, after they can sell their architecture services with this knowledge about well-being to developers, they will have some value that they can offer that differs from all these that now it's common right now. It's like decorators or facade or certain brands, so they can sell more. The developers sell more easier their apartments, and they will. I think it's developers are looking for this stuff, but they don't know how to manage it. So we got to teach all those students with this motif, and that's it.
Thank you very much. Timothy, would you like to come in?
Yes. Currently, we're having in my own department, I'm having a course on design, architectural design that has to focus on earth. So we have to design a clinic for the university. So we want to, we kind of frame it in a way to expose the student to real life situation on campus, and that the clinic will serve the entire community, and even outside people, the staff, the students, and their various friends can come and use the place. So we kind of frame the brief to be able to cater for the need of everybody around the university community. And one of the things we emphasize is flexibility, which I think we have to bring into our design, that even after we have pandemic and epidemic, we can always use the building for, after. If I want to tap back to the last question about various forms of contractor coming in to do one thing or the other, we have to emphasize to them that health matters. And even after the pandemic, we architects, we are going to make the design to look not just for the pandemic period alone, but adaptable to other uses. That's flexibility in design, adaptability, that the building or the structure being made by the architect is not just for that year alone. It's not just for 5 years or 2 years. It could mutate. It could be transformed. It could be user specific. You can come in and use it for other things. So that ability for that building to be able to do other things outside the issue of pandemic for that current thing, but could respond to other things that may come in the future. These are the kind of things where it's part of our curriculum. We are trying to build into it, that I think others can emulate it also, and we can actually use that to encourage, to tell investors that what you are doing now is not just to respond to what is happening now. It could actually be a money spinner for the future if you can come into it. And not only for them alone, that even the government can get involved to provide the money. Not only government, even religious body, churches, mosques, and private investors, can give you money to get this thing done. So these are the kind of vista we have opened up in the class, that whatever we are giving them to do, the proposal, the brief, is to attend to a real life situation and to be able to meet the expectations. That is one of the things we have done thus far.
No, thank you. I think this question of parallel use and multi-use is incredibly important. But Henry's just raised a really interesting point about typology, because we've got used to the idea somehow of the clinic and the hospital, and these classic, if you like, archetypes, almost stereotypes of curing and accommodating the lack of wellness in our communities. But is your point, Henry, that we need to somehow reinvent these ideas? Because I think it's a very interesting one.
Yeah, I think that for people doing in hospitals, and the architecture, the structure lasts for quite a long time, and then the mechanical system, which is absolutely critical for the clinical space to function. Say architecture 50 years, mechanical systems half the time, 20-25 years. And then your furniture is going to wear out in about 7 or less than 7 years because 24/7 use, and your medical equipment, and I think was 5 years, is outdated. So we see this misalignment in terms of our environment, and that once the typology is built, and then it was kind of interesting because hospital, once it's built, it changed its purpose. When somebody built a 400-bed hospital, then after that it's built, the key goal for the hospital is to keep it full. You need 85% census in order to let the business keep tangible. So that changed the way what the hospital is supposed to do to the community. Is certainly changing from keeping community health to actually make sure I have sufficient patients. And that this is where the facility, I truly believe we need to rethink what the facility do and how it contribute to healthcare.
Yeah, I think that point is, excuse me, I'm busy scribbling down notes. That's why I'm slightly skewed in my seat. But I think this question of rethinking the facility is true, actually, both of buildings for well-being, but actually of so many other archetypes that us as designers are habitually dealing with. The office has become more like the home, and the home has become more like the office, and that was actually happening pre-pandemic. And if you look at reuse in the city, it's an extremely dynamic thing. You know, everywhere banks are becoming bars, and office blocks are becoming lofts, and so on and so forth. And we're this idea of functional transformation is becoming fundamental to the way that we develop every single city centre, and actually, for that matter, outlying areas. You know, the suburb now has dead high streets throughout Europe, and I suspect in other parts of the globe as well. I'm going to move the conversation on, and I'm going to ask Robin to take the first one. And this third question is really very much to do with collaboration. And the question is about dealing with other experts. So in architecture and urban design, how can we strategically move closer to healthcare professionals? And by that, I mean doctors, nurses, carers, psychologists, holistic practitioners, and so on. And how would we have to transform, if you like, the agenda for both practice and education in order to make that move more concrete? Because the reality is that every single professional works within their own slightly hermetic bubble. You know, architects know other architects, urbanists know other urbanists, interior designers know other interior designers, lawyers know lawyers, etc., etc. And if we are to learn from the phenomenon of the pandemic, it seems to me that with particular regard to well-being, we have to be better at collaborating, but we almost need to coerce ourselves into such collaboration. Robin, what are your thoughts on that?
Well, you know, I think there's been this sort of belief that the architect has been the master builder, right? And I think it is giving way to the idea more and more that an architect is a facilitator of a series of conversations, that's our fundamental role in the world. And, you know, I think, Christina, you already kind of answered this question so well. I do think for us to move closer to medical professionals, and, you know, we need more emphasis on evidence-based design. We need to really allow the evidence and the research to change our practice, much the way medicine does. And, you know, we just don't do that. It's, you know, changes in the profession of architecture happen through litigation, and they happen when buildings collapse. But other than that, we're not necessarily, as a profession, embodying best practice and into the way we move forward. We're still sort of typology rule bound, like, you know, we have a different set of drivers, but I think it starts with, and then I'd love to hear other people answer this too. I think it's really about understanding and connecting the environmental and health consequences of our design choices. And what I've seen in healthcare is, and I think why healthcare is such an incredibly important, in a way, market or typology to take on this challenge, is that when you can connect the dots between a building decision and its health consequences to medical professionals, they will select the one that has less health consequence. But you know, those environmental and health consequences are often really difficult to connect the dots of. Like, it's really only been in the last 2 to 5 years that I'd say that the evidence around air pollution and fossil fuel use is compelling hospitals to decarbonize in the West. But now that evidence is clear and it's compelling and it's there, just the way they got rid of mercury and blood pressure cuffs, they will move to get rid of fossil fuel use. So that to me is at the crux of this. So how do we both own the choices we make as designers and embed that in architectural education? And how do we communicate the consequences of those choices to the clients that we serve, whether those clients are medical or corporate or communities or whatever, so that people collectively make better choices?
I think this point about evidence and data is actually pretty fundamental, and this issue of subjectivity, often I think is a spectre which can have potentially catastrophic consequences for architecture, whether it's through well-being or collapse or fire or God knows what. Christina?
Yeah, I would like to mention, sorry, a dissertation from a colleague from Chalmers from a few years ago. The dissertation the title is Evidence, Dialogue, and Intuition. Somehow in our practice, we need to base our process on best practice and evidence. Yes, we need also to talk and enable what you call, Robin, it's actually our work is to enable many stakeholders to come together around the table. I have seen this I had a hospital project in Colombia, and when we started the project, we brought with us our design dialogue tool, which is very common in Scandinavia, where you bring people around the table. It doesn't matter if they are managers or doctors or nurses or designers. You bring them around the table and you talk about the project together in a very democratic, equal atmosphere. And it was the first time they had sat around the table together. So I think we have to develop tools in our work on how to bring stakeholders together. And I experience that workshopping around design sometimes breaks down barriers because you step out from your comfort zone and you are equal to anybody else around the table. On the other side, it's not enough. It's not enough to listen to everyone. It's not enough to bring everybody together. It's not enough to collect experience and evidence. There is still that element of intuition that architects bring into the design process that is unique, that makes the same project probably resulting to hundreds of proposals, depending on the architect's background, inspiration, personality. And that is something that we need to have. We need to enhance that in the education as well, because that's our own responsibility. Is at the end, all these opinions and all this knowledge needs to be resulting in a physical environment and design choices. And nobody else can do that for us. So I have been in some projects getting answers from medical staff that I challenged, because we can't just design as medical staff want. Sometimes we need to challenge them and say, look, you want to do that, but have you seen that the evidence is the opposite? And it's this dialogue and this challenging, and at the end taking also our responsibility. I think it's a good way to go forward.
Kondika, please.
I'll just continue what Stina mentioned, that I think, and I see that the problem lies in our education, and that's why what happened, that we know that this is necessary, but we don't have the confidence to do that. Because we didn't practice it when we were in the academia. We are not exposed to the reality. So we know that we need to talk with medical healthcare professionals and the real clients and communities, but we don't know how to start. So I think that in the academia, we need to expose our students and so that they become confident. And also, most of the time, the students ask, and when I was also a student, I used to ask that how can I be useful to more and more people? Not only in our country, maybe we are serving only 5% of the people, the top, but 90% people they don't get the architect service. And we don't know how to go there because the academia is not making us confident to go there. So I think that we can ask this simple question: how can we be useful? How can and we can find ways. The way medical, the healthcare professionals they are doing it. They may ask, maybe they ask these questions, and that's how they are everywhere. And people know that we need to go to the doctors of the body, and we are the doctors of the environment, doctors of houses. But people don't know that because we didn't bring this idea to the people. That's why they don't come to architects. They don't know actually what architects do. So I think we need to, like healthcare professionals, we need to go to more and more people. Then there will be a demand side that architects can build, a beautiful building, not only beautiful building, but also healthy building, healthy environments. So and then I think the academia, universities also will produce maybe that type of students. I don't know. I mean, this is a big problem, I think.
But I think the phrase "doctors of the environment" is a wonderful one, and it really talks about we somehow have to democratize and make more accessible architectural services. And the reality is we're separated by the spectre of fee scales and percentages and architecture as a business from what we do as practitioners being embedded in the community. It's embedded in communities of money ultimately, and we've been through this before. Of course, we have to have money to build, but somehow there has to be a process by which we are serving those who most can benefit from architectural services. Timothy, I'm aware we're in the last 10 minutes of the session. We've covered quite a lot of ground, but let's have your thoughts and then start to draw together perhaps some conclusions from the session.
Yes, one of the things we got from the observation and insight from the COVID-19 experience is this issue of defensible space, a kind of a network of people that they can trigger off an early warning of COVID or somebody having that symptom, so they can report amongst themselves and to give a feedback to the people around them that can call the doctor. And I kind of have a kind of interaction with them in the teaching hospital, the doctors, and then we started talking about sick building syndrome, SBS. So, and that kind of make them to be interested in the work of architects. And so we were able to tell them that we are not just designing building, we take care of the cross ventilation in the tropic area. We kind of provide internal mechanism in the building interior to make conducive and in our design of flexible spaces that encourages this interaction among people. And everything springs from that concept I mentioned earlier, defensible space, that you can look out for your neighbor, and that is strongly emphasized in some of our designs. So that kind of situation starts a discussion amongst the doctors, among the nurses, then transfer back to the architects, and then we actually influence their policy in that version in our part of the world.
I think this concept of flexible space and the medium of social interaction is really fundamental. And Henry in chat notes has raised a question about, in education, are we adequately suited for interaction with people outside the professional circle? And I've always thought that the most successful architects actually are the ones who can play more roles, not just the professional role, because the reality is in the construction process, you have to be able to have a dialogue with somebody maybe pushing a wheelbarrow full of cement. You have to have a conversation with somebody who is a billionaire property developer. You have to have a conversation with fellow professionals and so on. And actually, we have quite a hermetic existence, both in academia and in practice. And whilst we do interact with many other individuals, the question of really penetrating other people's culture is often, I think, problematic. I'm thinking of a way to be able to maybe draw some conclusions together. We've had some extraordinary thoughts, I think, here. Ruben came up with a fantastic phrase about students and graduates feeling like orphans. I thought this was a very profound thought, and that somehow students and graduates didn't always feel that they were working in anything other than a moral void. I thought that was a very, very profound thought. And I think the question of the ethics and morality of the profession is really fundamental to everything we do. But what I'm proposing to do to try and wind this up is, in one word, I'm going to ask everybody to try and summarize what we need to do for the future in terms of transforming the agenda for architectural design and the broader concept of the health of the community. What might that one word be? If you have to go to two, that's okay, but I'm aware that we've got 7 minutes on the clock. Ruben, I'm going to start with you.
Okay, I gotta say just one word, but I believe it will be opportunity. It's an opportunity.
Excellent. Thank you. Robin.
I'd say, I think it's to catalyze transformation.
Okay, thank you. That's two, and that's fine. That's good. Christiana.
I think I would like to see more curiosity, to be curious about things, knowledge and other perspectives, and to be listening. Curiosity, I think, is something that I really appreciate in students.
Excellent. I agree with you. Timothy.
I think I have to emphasize the balance between equality and equity. You know, they sound so similar, but they are different. So yes. Equality has to do with giving things to everybody. You know, we want to share it around. And the equity has to do with sharing based on need. So the global world has to think of where the need is more, you know, in trying to distribute health and to impact our future. You know, we have to think more about equity. Equality is important, as I said, but equity is better where the need is. In Africa, in third world countries, in the developing world, I want to leave that last word. Think about them more.
Thank you. Kondika, your word or two.
I would say co-creation or co-create with communities.
Excellent. Thank you. And Henry?
I would say think construct. And that we've been dealing with the physical world for quite a long time. And I think there's some conversation about the policy experience and the digital things, well-being, wellness. I think our training gives us a way to look at and many of the challenges, regardless its form and its format, to provide a structure, provides an order, and then many times it's an order to establish order from chaos. And so the whole notion of construct, whether that's a physical or digital or experiential, I think that is something that we are best suited to contribute.
Thank you very much. I think many things have come out of the conversation, and these sessions are never about finding definitive answers. They're about provocations to thought. But I think something that constantly came out is about learning to talk with others, learning about others' culture, other professional cultures, but actually the culture of our users, and having a much firmer evidence base from which to work with when we're applying our intuition and our curiosity, in Christiana's terminology. And intuition is something that separates us from somebody who knows how to make a simple reinforced concrete frame. It's a question of knowing what to do with it, how to make that life enhancing. I think another interesting thing in the light of the pandemic is this question about the dialogue between interior space and exterior space. And there's this very complex issue, as we discovered during the lockdowns that we had in all our nations and regions throughout the world, that actually we needed that exterior space. We needed it very, very badly for our well-being. And suddenly it's denied to us. Yet the city is all about that thing of people passing through and people mingling. And how do you design healthily to create that kind of exterior space, which is dynamic and creates that social interaction? But also, there's the politics of exterior spaces, you know, without getting too much into Henri Lefebvre discussion areas, the right to the city, the policing and surveillance of exterior space. The wonderful thing from an authoritarian point of view is that the exterior space, if it's limited, it limits our ability to talk back to our governments. And that's an interesting thing. We've got 2 minutes. I'd like to offer those 2 minutes to any two of you who have something to say in 1 minute. Ruben.
Okay, one last thing to say. I have to say that this is an opportunity to offer or switch our services as professionals so people can understand that we are the improvers of environments, but not only the environment, the physical, but also the psychological. We need to help a lot also in mental health for healing and for going on in life. So that's, I think we can offer now students or everyone, like our office is not only construction, it's the improve of your kind of life or whatever. Thank you.
And one more.
Can I? I would say that I hope that what we have learned and what we had gathered so far, a lot of societies start to destigmatize disease and illness, that understand that health is part of the human life, and then something that we all can get sick, we can all get into an accident, and the healthcare facility and or in addition any kind of facility, you will be directly contribute and facilitate and for the quality of our life and the quality of society.
Thank you very much. I think that's a very positive thought on which to end the procedure. I'd like to thank the panel who've been absolutely magical. Some brilliant and highly provocative thoughts being aired here. And I'm going to hand back to Caitlin at this point with 1 minute on the clock.
Thank you so much, David, for facilitating this robust conversation, and for our panelists as well. Sincere thank you to all of you for your time and your thoughtfulness in these really timely, important provocations. I also just wanted to thank my colleagues, Angela and Mohammed. It takes a village to put on these events, so appreciate the partnership there. And thanks as well to our participants for joining this conversation today, as well as those of you who are going to be joining us on YouTube later on down the road. I just want to say thank you for investing your time in this conversation. To everyone, please do find out more information about the initiative at epidemicurbanism.com. And you can also find videos from today's session, as well as all the conversations on YouTube as well. So with that, I wanted to say a hearty thanks to everyone, and please stay well.
Thank you very much.
Thank
Thank
you.
Thank you very much, Caitlin,
Thank
Mohammed,
you
and
very
Angela.
much.